Osteobites. So glad you made time to join us today. My name is Christina Iptoma, and I am mom to Osteo Angel Dillon and the Director of Scientific Programs at MIB Agents. And today on Osteobites, we are talking with Dr. Robert Canter and Dr. Robert Rebhun from UC Davis about their study on inhaled recombinant human IL-15 dogs with naturally occurring pulmonary metastases from osteosarcoma or melanoma. It's a phase 1 study of clinical activity and correlates of response. Thanks so much, Dr. Canter and Dr. Rebhun, for joining us on Osteobites today. We are going to be talking with them about this results from the study in dogs. And so we're really looking forward to some slides with some cute dogs in them. That's going to be the highlight for today. I'm really happy to have you, and thank you, Vicki, for joining us as our panelist today. Vicki is an Osteo Warrior and MIB Agents Junior Advisory Board member. A little bit more about our guest today. Dr. Canter is a surgical oncologist with clinical expertise in the multidisciplinary management of sarcomas. He also runs a translational research laboratory, which focuses on the therapeutic and mechanistic effects of combining natural killer cell immunotherapy with other treatment modalities to overcome NK dysfunction in the tumor microenvironment of solid tumors, including sarcomas in both humans and dogs. He serves as a co-leader of UC Davis Comprehensive Cancer Center's Comparative Oncology program, and his laboratory is one of a select group of labs internationally, which is studying canine NK cells, including first-in-dog studies of canine immunotherapy and adoptive transfer of NK cells in dogs with osteosarcoma. And Dr. Rebhun is an associate professor for the Department of Surgical and Radiological Sciences and associate director at the Center for Companion Animal Health at the UC Davis School of Veterinary Medicine. As a veterinary oncologist, his research focus is in the fields of comparative and translational oncology, with specific interests in metastasis and novel therapeutics. He received his Bachelor of Science and Doctor of Veterinary Medicine degrees from Cornell University, and he didn't have to travel far for those since he originally hails from Ithaca. And he received his PhD in cancer biology from the University of Texas at Houston. After completing his clinical residency training in medical oncology at Colorado State University, he joined the faculty of UC Davis in 2008. Welcome, Dr. Canter and Dr. Rebhun, and welcome to everyone joining us today. Please feel free to add any of your questions for both doctors in the Q&A. And before we get started, we have a couple of announcements. We are excited to launch our new monthly newsletter called Connective Issue next week after Labor Day. It will include info of interest to our osteosarcoma community, including recent news and papers, open clinical trials, job postings, info about MIB events and programs, and spotlights on members of our community. To make sure you get all of this info delivered straight to your inbox, just go to our website and hit the Join Our Community button to subscribe. And there are a couple more ways you can support MIB Agents and our programs now and in September for Childhood Cancer Awareness Month. You can still outrun osteosarcoma with us for the rest of the month. You can run, walk, cycle for a 5K, 10K, or half marathon, and you can rack up your mileage for the whole month of September. It's a really great way to raise awareness for childhood cancer and also raise funds. And we'll put a reg link in the chat if you're interested in participating in that. And you can also make and sell bows for the mailbox or the front porch for your community, or you can just purchase a bow, which will also help raise awareness and funds for pediatric cancer. And we'll put some more information about that in the chat as well. And we would like to thank the sponsor of this episode, BTG Specialty Pharmaceuticals. BTG provides rescue medicines typically used in emergency rooms and intensive care units to treat patients for whom there are limited treatment options. They're dedicated to delivering quality medicines that make a real difference to patients and families through the development, manufacture, and commercialization of pharmaceutical products. Their current portfolio of antidotes counteracts certain snake venoms and the toxicity associated with some heart and cancer medications. Their drug Varaxase is for high-dose methotrexate toxicity. And then with that, I'll hand it over to Vicki to introduce herself.
Hi, everyone. My name is Vicki Hoy, and as Christina said, I'm a Junior Advisory Board member and an Osteo Warrior. I'm currently studying finance at Villanova, and I'm actually in my dorm right now, but I had to blur the background because it's a little bit messy in my dorm, but I'm a week into classes now. Anyways, I'm so excited for our guests today, so feel free to take the stage, Dr. Canter.
Okay, well, great. Well, thank you very much. It's a real pleasure to be here today. And, we really appreciate the invitation to talk to you about our work and our interest in osteosarcoma, specifically related to dogs, but obviously also related to humans. And thank you for that very kind introduction. As was mentioned, we're going to be talking to you today about our work in immunotherapy in dogs with all kinds of cancer, but in particular osteosarcoma, because osteosarcoma is actually a very common cancer in dogs. And so one of the things that makes this, I think, relevant as part of research and as part of novel development of new treatments is sort of the gulf between a lot of basic research, which is done in the lab and is done in mice, and treatment of patients, which is obviously done in the clinic and in the real world. And in the lab, we're frequently studying very homogeneous cohorts. Okay, the mice are usually young, they're usually female, because like mice are like people, females fight less than the males. They're usually lean, inbred, and what we call specific pathogen free, or a very highly controlled environment, which there's reasons for that. Some of it is just practical, and some of it is just the way a lot of the very basic immunology and cancer biology has been worked out, and that's very valuable. But it has limitations, and especially in sort of making new treatments that work in mice, that work in the lab, getting them to successfully work in people. And the statistic you'll commonly hear is only about 10% of treatments that work in mice actually ever become successful in humans. And it's probably even lower than that, because the denominator of things that actually even ever get tried in people is lower than the number of things that are tried in mice and seem to show promise. And one of the big reasons for that, in our view, and one of the things we're interested in is just the heterogeneity and the diversity of people, which obviously is relevant and sort of intuitively clear. But the patients that we're treating are aged, at least for many cancers. Osteosarcoma obviously is not, but they're both male and female. Unfortunately, obesity is becoming an increasing problem, and that has implications on cancer development and cancer therapy. Very genetically diverse and heterogeneous. And also from an immunological perspective, they have a very extensive history of pathogen exposure. And some of that is good with things like the microbiome, and some of that is potentially bad. But all of those things affect your baseline immune sort of repertoire and how you respond, and especially in things like immunotherapy, which, as you may know, is really kind of revolutionized cancer therapy in the last 10 years or so. So this is a big sort of, gulf between how cancer is studied in, especially immunotherapy, is studied in the lab versus how it's applied in the clinic. And that's why for us, studying cancer in dogs, we think is very, very valuable, because it's sort of a bridge between studies in mice, which are very basic and very what we call mechanistic, and studies in humans, which are clinical trials, but they take a lot of time, they take a lot of money, and they often can be, ambiguous, where we're not really sure if it worked or it doesn't work. And so it becomes hard to know exactly how to apply them. And so that for us is really one of the strengths of studying immunotherapy in dogs, is because their cancer is so similar to the cancer that humans get. And this is especially true for osteosarcoma. And it's especially true for immunotherapy, because their cancer develops what we call spontaneously, or naturally occurring, in the setting of an intact immune system. And that's very important, because although we're trying to get the immune system to respond to cancer and to attack it, the cancer has developed in a way to evade the immune system, because otherwise it never would have developed. So that's an important sort of tension in cancer development is that it's sort of intrinsically found a way to escape immune detection to become clinically evident. Dogs are very outbred, although there are also, interestingly, a lot of specific breeds which are highly inbred, and that also has interest because of the kind of comparison of inbreeding in specific breeds versus outbreeding across the board. And we know certain diseases and cancers are more prone in certain breeds. And again, that's very interesting because it can help, give insights in terms of the interaction between genetics and cancer and immunotherapy. And then another really important aspect of studying cancer and immunotherapy in dogs is that their environment, their exposures, their microbiomes are all very, very similar to humans in many ways. And so that's sort of the interaction with the environment, what we call the epigenetics, is very similar, and therefore seems to make it more translatable in terms of what we find in dogs and how it may apply to humans. So that's kind of the background of what we call comparative oncology, and why we think it's important. And osteosarcoma, as I mentioned, is one of the most common cancers in dogs, interestingly enough. It probably is more, or it seems to be more common in dogs than it is in humans. And the statistics are not as good in dogs. We don't have a SEER database like we do in humans. That I would like to see that happen one day. But some people say as many as 50,000 dogs a year are diagnosed with osteosarcoma in the US. And that's a lot more than humans, which is around 3,000 or so. So there's a lot of dog patients out there that need therapies too. And as Dr. Rebhun always reminds me, and of course I know this, but we're not just, it's important for us to learn to apply this to humans, but we're also trying to treat these dogs who are also suffering from aggressive cancers and need treatment there too. So that's sort of the kind of overarching, framework for our work in terms of why do we study cancer in dogs? And this is not cancer we're giving to the dogs. This is, like I said, cancer that develops spontaneously, randomly in dogs as it does in people. And it's for us an opportunity to speed translation, test out new therapies, which may take too long or too expensive, or just never get a chance to test them out in humans, and to really kind of advance the immunotherapy pipeline, which is especially important for osteosarcoma. It's especially important for natural killer cell therapy, which is something that we're very interested in. And there's really a unique chance to really do some of this work in dogs. And NK therapy, not to get too much into the weeds, as we say, natural killer cells are these very unique cells in the immune system, which can, spontaneously, naturally kill cancer cells and kill virally infected cells. And so there's a lot of interest in trying to get them to work in cancer as a cancer therapy. And there's advantages to them in terms of being off the shelf, unlike a lot of T-cell therapies, and they don't seem to cause as much toxicity as things like CAR T-cells, which you may have heard about. But there's still barriers, and they really haven't made any breakthroughs like some of these, CAR T-cell therapies in other cancers have. And so again, those are things we're looking at, we're studying, in our clinical trials, where we're trying to treat the dogs, trying to improve their outcome, but also learn from the science as well. So this is the trial that we just published on, and Dr. Rebhun is going to kindly give more details about it. And he, not only is a close collaborator and scientist, but he's also the clinician who's taking care of these dogs, and he develops a very close relationship with them. But this is the schema where we were giving inhaled, so that giving it as a breathing treatment, interleukin-15, which is a cytokine, a very strong stimulant of the immune system, and giving it in an inhaled fashion in order to deliver it directly to the lungs, where lung metastases are a major problem in dog osteosarcoma, just like human. to try and get it to work at the lungs where it needs to work, but also limit the exposure to the rest of the body. Because one of the major problems with cytokines like IL-15 and interleukin-2 is that they're so strong that it's really hard to really find the right balance between seeing effects and seeing toxicity. They can be very toxic. And that's really, sort of the genesis of this trial in terms of trying to find a better way to, find the dose response where we can get responses and not have as much toxicity. Now, we had to use human IL-15 in this trial because of availability of the drug and availability of it in a way that we can give it in a clinical fashion. And so that's obviously an interesting wrinkle in this trial, but an important one. And so that limited us in terms of how long we could give it. We could only give it for 14 days because it's a human cytokine, a human drug molecule. The dogs will develop an antibody response to it. And so if we give it longer than 14 days, they'll either just neutralize it because of antibodies, or even in rare cases, they can, have what's called anaphylaxis, where they have a very severe allergic reaction and it can have side effects. So we gave it for 2 weeks. We knew that that was an issue, but we also thought that we could, assess the responses and the immune effects and have it be a sort of foundation or a building block for our work. And why IL-15? Because it has advantages over interleukin-2. Interleukin-2 is sort of the poster child of cytokines, dating back 30 or 40 years. But interleukin-15 seems to actually have a more favorable mechanism of action in terms of its effect on the immune cells, in terms of stimulation versus suppression. And so this is the dosing that we did. We took dosing basically kind of modeled on some human studies in terms of, the doses that were given intravenously or subcutaneously. And I love this video. I don't have the whole video because I'm not technically very savvy, but Dr. Rebhun and his team made this video to help show the clients of the dogs how to administer it, because they would take this drug home with them and give it, twice a day for 14 days. And so they made this video for how to do it, and it's very user friendly. And the dogs were very, very compliant, if you use that term in dogs, in terms of having it done to them. They just put this cone over them and infused it, or not infused it, nebulized it, aerosolized it through a regular, aerosolization machine that people use for giving, albuterol treatments to their kids. And it worked very, very well. And it's a really cute video. It's only about 8 minutes long. And so now I'm going to turn it over to Dr. Rebhun to give a little bit more details of the actual results of the study and some of the follow-up trials, and then I'll give a little bit more after that.
Yeah, thank you. Let's see. Did that switch out okay? The screen share? All right. So yeah, I just want to echo Dr. Canter. Thank you for having us today. We're excited about this and kind of the next step. So we appreciate the opportunity to kind of chat about it. My slides will be pretty quick. I think I just wanted to kind of take you through kind of some of the clinical aspects and high altitude, and getting a little bit more into the weeds, and then kind of handing things over to Dr. Canter, who will talk about the correlative studies. But just to kind of set a baseline, there were 2 tumor types that were within this phase 1 clinical trial. And so we took dogs that had either spread metastasis of osteosarcoma or malignant melanoma to the lungs. And so that is something that we commonly see in dogs. They develop these tumors, and these tumors are aggressive and like to go to the lungs. And just kind of because it is quite different from the human side of things, dogs, one of the other things about dogs is that not only is their lifespan shorter, but the cancer, many of the cancers that dogs get progress much more rapidly. And so it gives us an opportunity. Again, we want to help the dogs, but it also gives us an opportunity to kind of more quickly evaluate novel therapies, because unfortunately they usually progress so quickly. And so the example with canine osteosarcoma if we only do adequate local control or amputation many times in dogs, if we don't give them chemotherapy, the median survival time is about 4 to 6 months. If we do give them chemotherapy, we can get that median survival time up to 9 or 10 months or so, but still not great. But I think importantly for this trial, once they have distant metastasis to the lungs, the median survival time is somewhere between 2 and 3 months typically. And these numbers are quite similar in melanoma. We don't have great chemotherapy that works for melanoma, but again, reasonably short or fairly short survival times, and particularly when they have spread to lungs, it's very short. And so I think that's an important kind of baseline going into the data that we're going to show you. So keeping that in mind, and also realizing this was a phase 1 trial. And so Dr. Canter showed very nicely that, we kind of, for a phase 1, the primary thing that we're looking for is actually to determine what a safe dose is. So typically that's been kind of a maximum, what we call maximum tolerated dose. So we kind of use this step up to see, what is a safe dose to give. And so it really is a very early clinical trial, because not all of these dogs are getting the same dose. And the very low dose, the first ones enrolled, might not have any toxicity, but it might also not have any efficacy. And so as we go up, kind of the risk and potential benefits kind of both go up. And so, the first step in evaluation of combination therapies, which was our ultimate goal here, to either combine with NK delivery or to combine with standard of care chemotherapy, we first needed to find out what dose is safe. And then the kind of secondary endpoints of this are to evaluate kind of, feasibility. Can we do this? Is it safe? And is there a signal of efficacy? Is there some indication that this should move on to additional studies? So the way this was set up is when the dogs were diagnosed with lung metastases that are spread to the lung, we would take some samples, but the main thing is when they started the study, we would give them the inhaled IL-15, and this is twice daily, so every 12 hours roughly for 14 days. And then we would come back and take chest x-rays and see if anything happened. So we will, with the blood work, and as well as clinical, physical exams and owner evaluation forms, we'd see if there were any side effects. But then when we see if the tumor shrank, that's at day 28 or day 42. So either 2 or 4 weeks after completing the inhaled. So I think that's important, is there's only this 2-week window that we gave this inhaled therapy. And this is kind of the meat of it, and it says preliminary. I need to update that since we published it, but 11 dogs with melanoma and 10 dogs with osteosarcoma were enrolled. At each of these cohorts that Dr. Canter showed, so we started at 10 micrograms, twice a day. We went to 20, 33, 50, and all the way up to 70. We had one dog that had a potential side effect early on, and so that we actually expanded out. We did 6 dogs at that dose, but we didn't see any other side effects. So then we continued kind of going up. At this highest dose, at the 70 micrograms, this was actually 2 patients with melanoma that developed kind of complications within their lymph node, which is abscessation, which we thought could be possibly related to the therapy. And so based on the fact that, 1/3 of the dogs had something here, we defined what this maximum tolerated dose, or the kind of recommended dose moving forward, was this 50 micrograms. And, again, toxicity was the most important thing for this phase because we were going up in dose. But of the 18 dogs that were, so 21 enrolled, 18 of those were evaluable for response. Actually, almost about 40% received what we perceived as some sort of clinical benefit. So 5 stable disease. There was 1 partial response, which means that the tumor shrank more than 30%, and 1 complete response where all of the metastatic lesions went away. And I think that one of the key takeaways of this is that we did see durable responses even after this 2-week window of response. So if we can induce this immune response and clinical kind of shrinking of tumors or even stable disease, that it could last much longer than just those 2 weeks. And just a couple of examples. And again, we show you the ones that responded. So this certainly isn't every dog, but this is a dog that has metastatic osteosarcoma. So you can see that there are several lesions here, and this largest one here, there's actually two kind of superimposed on each other. But this was given in November. And after 2 weeks, remember, median survival for these dogs is 1 to 2 months. And so, we're out, several months here. And the largest lesion is almost gone. About 3 out of the 5 pulmonary nodules disappeared. This dog actually had complications associated with the local, the primary tumor site, and developed an oral nasofistula, and was unfortunately euthanized for that reason. So we saw really good responses in the lungs, and we were happy with that. This is a patient that had melanoma, which if you look closely, and I should have said, in the dog, many of you aren't used to looking at this. This is actually the humerus. So the head is up here. The tail is down this end. This is the heart, lungs, and this is the abdominal cavity with liver and such. So you can see all of these pulmonary nodules here are not supposed to be here. Those are metastatic tumors from the melanoma. And this dog actually, these tumors shrank in about a month and a half after treatment. And this was a year later. So these lesions went away. This dog was quite old and actually developed neurologic signs and was euthanized in March of 2021. But after 2 weeks of therapy, these tumors shrank for over a year. So
Dr. Rebhun, sorry, just a question on that last slide. So,
yeah.
So that was showing a durable response of about a year, and just curious what after they were given the treatment for those first 2 weeks, how quickly do you actually start to see response?
Yeah, for this particular dog, this was actually right when COVID shut down everything at the end of February. So we were supposed to be getting radiographs of these dogs 2 and 4 weeks after completing therapy. This dog we didn't get until I think 6 weeks after it completed therapy, and they were all gone. So we know that it moved very quickly, as opposed to this dog. For time's sake, I didn't show it, but this dog actually had stable disease in the first month, and then they shrunk and continued to shrink over the next 3 months. So a little bit different in those 2 patients, but good question. So just want to get moving a little quicker so I can hand it back over to Dr. Canter, but because he'll talk about all the correlatives. But I think some important take homes was that this was very well tolerated in the dogs, so we saw very few side effects, and there was this preliminary signal of efficacy, and that duration of response when we saw it could be extended even though we only gave 2 weeks. And I think part of that might be explained some of the things that we did. So we looked at basically the levels in the blood of IL-15 after we give it inhaled. And the thought is that we're giving much higher doses to the lungs than we'll see systemically, and perhaps that's why it's well tolerated. And indeed, the data, this is probably a little bit confusing, but the data hopefully supports, if it makes sense, supports that. These are basically levels over a period of time after we give the inhaled IL-15, and we're measuring this in the plasma, so blood levels. And we can see in general, the higher the dose that we went in dogs that got 33 versus 50 versus 70, it tended to have higher levels. And this is just a time course over the hours. So not only did we see these levels in the blood, but we saw that they appeared to last, 6 hours or longer after an inhaled. And when we look at, when we actually compared that to dogs that got this delivered subcutaneously, so an injection got, very, very high levels, up to, almost 2,000 picograms per mil, whereas the dogs that are getting inhaled have much lower systemic levels. So we think this is being held in the lungs, and perhaps that's why we're seeing more activity. But we still did see these significant cytokine responses. So IL-15 induces changes in other immune pathways and cytokines. And so importantly, we did see it still occur. We saw an immune response in these dogs, despite the fact that they had much lower systemic exposure to this drug, which is probably why it was fairly well tolerated. And then again, quickly, so we were encouraged by the signal of efficacy and safety. And then to kind of show you a little bit about the next step, this is a paper that was published not too long ago, in March of last year. So this looked at 324 dogs. And I told you that, you know, the standard of care for these dogs are amputation, and we follow them with standard chemotherapy. So this paper then randomized them to get a couple other things. But one of the major things that came out of this for the veterinary side is that we realized in this large population of dogs that carboplatin chemotherapy fails in about 40% of dogs very, very quickly. And so at even 15 weeks, despite the fact they got 12 weeks of chemotherapy, 40% of dogs are developing metastatic disease that early. And so based on that, we realized that, you know, there is this cohort of dogs that do very poorly with chemotherapy. And so what we wanted to essentially do is design a study where we could combine this with chemotherapy in some way to see if we could help out those dogs that fail very early. Because if we wait until after chemo, it's too late for these dogs. And so, again, we just switched things up a little bit to say that this particular chemotherapy, this trial, the dogs will get amputation and chest x-rays. We sneak this 2-week therapy in here post amputation and before they start the chemotherapy. And then the main thing we're looking at is proportion that are going to be disease-free at 15 weeks. So hopefully that makes sense. I know I'm going a little bit quickly here. But we are actively enrolling at 4 sites for this through the Comparative Oncology Trials Consortium. We're working together with NIH and other schools, including Wisconsin, Colorado State University, and University of Illinois. So we're enrolling dogs at all of these sites. We've got the majority of dogs, I want to say we've got about 39 out of the 40 dogs enrolled. So we're moving very quickly on this and looking at to see if we can potentially help these dogs that fail early, or if it may even do better, you know, in addition to chemotherapy long term. So acknowledgement slide, but for the sake of time, I will hand things back over to Dr. Canter.
So yes, as Dr. Rebhun mentioned, you know, the results of our phase 1 trial we thought were encouraging. We saw some actual tumor shrinkage, some responses. We saw stable disease, and also about an additional 5 dogs. And given that it was only 2 weeks of therapy, we thought that was meaningful. And we established a maximum tolerated dose for follow-up trials and a recommended phase 2 dose. And what we also saw in some of the correlative studies, which I won't belabor, is we saw that the immune system in these dogs was responding. The NK cells and the T cells were being activated, suggesting that was the mechanism, that the inhaled interleukin-15 was stimulating the immune system and stimulating what we call the cytotoxic lymphocytes, which can attack cancer. And one of the things we looked at are what's called killing assays, which is when you take your NK cells and you expose them. This is in vitro, you know, in the lab. We take the blood back to the lab and we isolate the NK cells, or we take just the overall white blood cells in the blood, which have NK cells, and we mix them with tumor cells. And in this case, you know, an osteosarcoma cell line from dogs. And we look at the number of tumor cells that get lysed or get killed by the blood cells. And our hypothesis is that we would see increased cytotoxicity or increased killing over time in response to the drug, the cytokine therapy, and that the dogs who had the greatest increase in killing potential killing activity would have the best response. And that's basically, in a nutshell, what we saw, which was very encouraging. And we looked at both melanoma and osteosarcoma because this, as was mentioned, this trial included both of those types of cancer because those are both very aggressive cancers in dogs, and they both are cancers that go to the lungs and often go just to the lungs. So treating lung-only disease is a significant research need. And so, like I said, we did see that cytotoxicity on treatment was higher than the baseline. So there was immune activation, and the dogs that had the greatest increase in cytotoxicity had an association with better survival and better response. So that to us was suggestive that the cytokine was working in the way we were hypothesizing that it was working. And we were also doing, and we continue to do, high throughput sequencing on the immune system. So we're not doing as much sequencing of the tumors, although that's obviously important and something we're interested in, but we're interested in sequencing the immune cells and looking at their RNA profile of how they're being turned on or turned off by the drug and by the cancer and so forth. And what we saw, this was early on, about the first 7 dogs before COVID really shut everything down, was that there was a grouping based on the NK gene signatures between the dogs who responded. Here, this was patient number 4 and patient number 2, versus the dogs that didn't respond. So there was a separation or a clustering based on clinical outcome, at least, in this smaller sample size. And what was also interesting, because these, remember, we get samples over 4 time points, was that they tended to kind of group by dog. So the different colors, I don't know if you can see this, represent different dogs, and the different shapes represent different time points. And there is some movement by time point, particularly in the patients who did better. But they're still, grouping by color, which suggests that a lot of it seems to be, at least in this setting, sort of hardwired in. So, and that's one of the controversies, or not controversies, these sort of areas of interest in the field is, do you respond based on kind of where your immune system is at the beginning, or do you respond because of the way you change over time? Because, everybody kind of starts out the same, but some people respond differently. And at least in our data, if that makes sense, it seems to be that it's based on where they are kind of at the beginning, and whether that's because their immune cells are different genetically, or, like I said, epigenetically because of their exposures and all that stuff is an open question, and one we're very interested in. And we've been continuing our sequencing because that's really one of the best ways to analyze NK cells, especially in dogs, and looking at some of these questions, and also looking at how it kind of fits in to the different species that are so important, humans and mice. And this is some other kind of cool data that we find very interesting, kind of circling back to the whole issue of inbred versus outbred. And dogs are sort of right in the middle. And this is a complicated graph here, what we call a similarity matrix. But if you look at these boxes here, the colors represent how closely linked the sequencing data are between the subjects. Now, mice are highly inbred, obviously, and so their NK cell sequencing is almost superimposable. And humans are highly outbred, and so there's tremendous diversity. But what's interesting is that dogs are in between. And for this study, we did just beagles. And so even though beagles are an inbred breed, so to speak, they still have kind of an intermediate between humans and dogs in terms of their NK cell sequencing profile. So how does this relate to humans? I mean, obviously, we sort of mentioned that osteosarcoma is very similar, and dog physiology, cancer biology, immunology are similar, but obviously it's not exactly the same. And so more work needs to be done. And one of the ways we can even see this is osteosarcoma is more common in younger people, in humans. It's, adolescent and young adult, primarily, but interestingly in dogs, it's more of an older dog affliction. And the other thing that's interesting about dogs is it's more common in larger dogs, larger breeds. And so is that, because they just have bigger bones? I mean, obviously, probably not, but why is that is a question, because that's seems to be a subtle difference between people. So there are important similarities, obviously, but it's also important to remember that there are differences as well. So we are also, one of the ways we think this is relevant to humans is that obviously we know that immune cells and tumors are important. And one of the problems with osteosarcoma and just sarcomas in general in humans is they tend to be infiltrated by low numbers of immune cells. But even though there are typically low, more is better. And we see this is some of our own data from a prior publication, but other people have published that in human sarcomas, more immune cells are better. And that primarily is for T cells, which has historically been the main interest in immunotherapy. But we've been looking at it in NK cells, and these are from human samples. And we see that more NK cells seem to be associated with better outcomes as well. Although if you're a critic, which I like critics, you'll notice that these p-values are technically not statistically significant. They're always like p.07, p.08, which always gives me a little heartburn. But hopefully it's not spurious. But this seems to be suggestion that NK cells are also important in human sarcomas. And so, that's number one why we think this could be relevant to humans. And then what we've been looking at more so in detail in some of these benchtop and what we call correlative assays, we've been looking at TIGIT. And TIGIT is a new checkpoint that is receiving a lot of interest in immunotherapy. So we've all kind of heard of PD-1, PD-L1, I think. And that's what's been working in human melanoma and lung cancer and bladder cancer. Unfortunately, hasn't worked very well in sarcoma. But some of these newer checkpoints are now being developed for antibody targeting those. And we've been very interested in TIGIT for two reasons. Number one, we think in our data that TIGIT is sort of the critical what we call exhaustion marker in NK cells. And we know that T cells don't work very well in sarcomas, but we think NK cells have a role. And so that's why we're interested in TIGIT. And we've seen our data show that TIGIT is expressed in sarcomas, including in the tumor infiltrating lymphocytes. And more TIGIT tends to be associated with worse outcomes. So we're looking at ways to combine IL-15 with TIGIT blockade. And so do dog NK cells express TIGIT? Well, we have evidence for that as well from our sequencing data in both beagle blood on the left here and from some of our patients on the trial that we were just discussing on the right. So one of the things we're interested in now is combining IL-15 inhaled, for example, with TIGIT blockade, because we think it could be sort of this 1-2 punch that a lot of people talk about, where you give something to give gas to the immune system to stimulate it, and you give something to take away a break to also prevent the immune system from being tamped down by some of these checkpoint pathways. And so we've done some of this with patient samples, but in the lab where we expose them to IL-15 to stimulate the NK cells, and we show that they respond to 15. So these are human samples, whether it be blood or from tumors. I'm a surgical oncologist, so I'm trying to treat patients by surgically removing their tumors, and we then can look at it in the lab, and like I said, to see that the TILs from the tumor respond to IL-15. And then when we then do this 1-2 punch that I mentioned, where we give them IL-15 and then we add TIGIT blockade, we also see even better responses. So we're hoping that this is, you know, a path forward for us for a novel therapy in terms of combination. Now, we don't have a TIGIT antibody in dogs right now, but that's something we're hoping to see. And there are other checkpoints as well that we're interested in trying. But this we think could have relevance to humans as well, for example, because there are TIGIT blocking antibodies that are in clinical trials in humans. So in summary, I hope I haven't gone too long. We think that dogs are really a valuable, innovative model to bridge bench to bedside immuno-oncology approaches. Our data seem to support that inhaled IL-15 is active in dogs with osteosarcoma, with lung metastatic disease, and potentially as an adjuvant therapy after amputation. And we're looking at immune monitoring and sequencing and transcriptomics as a way to increase our knowledge of NK biology, but also help to identify biomarkers which can help us further build on these results. And so our future directions, as I mentioned, we're looking to combine IL-15 with TIGIT blockade. We're looking at microbiome studies. That's a hot area in immuno-oncology. And obviously, we're looking to try and find a way to translate the human clinical trials. And this is a picture of me and of my dog and me. The Cancer Center wanted me to have a picture of that. So it's not just because I love my dog, although obviously I do. You know, these are all of our funding sources and collaborators. You know, our vet school is fantastic, one of the best in the world. We couldn't do this without them. And we've had generous support from a lot of funding agencies. And these were the people in my lab from about 2 or 3 years ago who have now moved on to bigger and better things, and we miss them, but we're very proud of them. So thank you again for your attention, and we'd be more than happy to answer any questions.
We just had one question come in the chat. Someone asked, did the IL-15 dogs have prior chemotherapy exposure? And do you anticipate a more robust response if given simultaneous with chemotherapy?
I can take a quick shot at that, and I might leave the second part to Dr. Canter, but many of the dogs in our trial did, because this phase 1 trial, the dogs had already developed metastatic disease to the lung. Many of them had already received chemotherapy in the past. Some of them actually had received some form of immunotherapy. Some of them were actually previously included in that dog study with the 324 dogs. There was some immunotherapy in the past. Many of the dogs got chemo, and some of the dogs actually also had radiation therapy as well. So it was a heavily pretreated population. And I'll kind of segue into Dr. Canter's response for the second part. I think, you know, one of the questions that we are asking is, you know, how chemotherapy may impact this immune response, and, you know, is it possible that you know, that the chemotherapy that we're giving after the IL-15 could actually, you know, maybe negate some of the immune response that we're hoping to induce? I guess that's a fear, but there are other ways where I think that they could be additive or synergistic. And Dr. Canter is, I'll push that over to his side of the table.
No, I mean, I totally agree with you that historically, and still to this day, that there, you know, the thinking was that chemotherapy was suppressive, and therefore would limit the immune system from responding. But I think, like a lot of things, it's much more nuanced than that. And there are many situations that chemotherapy may be beneficial. It kills cancer cells, and those cancer cells then release antigens, part of the cells that then can be picked up and stimulate the immune response. And it depends on the type of chemo. Different chemos affect the immune system and the other cells in the body in different ways. So it's actually an area of a lot of interest right now. Is combination therapy in general is obviously very important, but how to kind of rationally combine them. And there are some studies that show that chemotherapy actually can promote or increase immune responses. So I think that's an important question, because there could be beneficial effects of chemotherapy to make immune responses better. The other thing that's interesting too, kind of along those lines, is it's probably more an impact of tumor burden. I mean, pre-treatment, affects the bone marrow, and it affects, immune reconstitution, but tumor burden in and of itself can suppress the immune system. And so that may be more the factor when patients have really progressed through a lot of things and they have a lot of tumor burden. So treating earlier with immunotherapy may be better. And we've seen that in some of the neoadjuvant trials, where the response rates seem to be better when immunotherapy is given earlier in the course.
I'm curious, Dr. Rebhun, you also mentioned some of the dogs had radiation therapy, and kind of similar conversation to chemotherapy. If there's any kind of synergistic value of radiation therapy in triggering immune response. And I'm wondering if in your data, you have any like correlative data on that, kind of the response in dogs that received radiation therapy?
Yeah, no, it's a great question. And I mean, I think, the how we build this into the kind of the traditional therapies is something that we're actively working on. And so I'm just kind of following up real quick that, Dr. Canter and I have a trial that's moving forward, which is, we haven't talked about, but based on kind of giving a little bit of chemotherapy prior to starting the inhaled. So we are kind of testing all those scenarios. And for the radiation, yeah, Dr. Canter actually collaborated with one of the radiation oncologists here, Dr. Kent, who is actually one in the photo early on. Dr. Kent's a veterinary radiation oncologist, and they looked exactly at that. So combining radiation therapy with immunotherapy for dogs that maybe weren't good candidates for amputation, and looked at immune responses. And they did see some, I think along with Dr. Monjazeb was in those studies at the Cancer Center, they did see some systemic potential responses, despite kind of only treating locally with radiation and then a systemic immunotherapy. Dr. Canter, do you have anything to add there?
No, I agree. Again, it seems to be that the radiation sort of acts as a kind of vaccination type of thing, where it kills cancer cells, and those cancer cells then get picked up by the immune system and act as a priming of the immune system to respond.
Yeah, and I would just add, your questions are right on kind of our track of thinking. This IL-15, while it was encouraging, by itself, it's not, a magic bullet. It's not something that was curing disease. I think the combination of this with these standard treatment options or with other immunotherapies is kind of the direction that we are headed as a group. We're encouraged, but we know there's lots more questions and potential trials that we can do.
Another question I had was that when you give dogs chemotherapy, are these similar proportions as you give to like humans with like a protocol chemotherapy treatment, or are they much less, proportionally?
Yeah, good question. It's so our chemotherapy in dogs, the goal is a little bit different. With dogs, we have to be able to kind of we can't kind of push them as hard as you all have been pushed with chemotherapy. And so dogs, we kind of landed on this, what we call standard of care protocol, is a platinum-based protocol with either 4 or 6 doses of carboplatin. And carboplatin tends to be better tolerated than cisplatin. So I think to speak to your question, dogs typically do very well on chemotherapy. Their quality of life is very good, but we're probably sacrificing a little bit of impact and efficacy because we're wanting them to have good quality of life throughout what time they have left. And so there have been some trials looking at combinations of like cisplatin and doxorubicin and even methotrexate. They didn't seem to do much better. And so we kind of landed on, well, this balance of carboplatin seems to be effective, but it doesn't, they still have a good quality of life. And it's just kind of where we've landed in that happy medium. Did that answer your question?
Yeah, no, definitely. Thank you.
And I know we're almost at time, but I thought I'd sneak in one more question about, you had a slide about the sequencing, and I just wanted to just clarify and make sure I understood. So there was a slide where there were kind of the clusters, and I think you had mentioned that you were sequencing the immune cells as opposed to the tumor cells, which is kind of, I guess, what I'm more familiar with. And so can you kind of speak more to that? Like, what does that sequencing data tell you when you're sequencing the immune cells?
Right. So this is what's called RNA sequencing, or RNA-seq, which is different from tumor sequence like Foundation One or Tempest or some of those things, where that's excuse me, DNA sequencing and looking at mutations in the cancers, and that's where you get the report of the different mutations, looking for targetable drugs to apply. So we're doing RNA sequencing, which is looking at not what mutations they have, but what genes are expressed, what pathways are active, to get an insight into, is the cell functional, hyperfunctional, suppressed, exhausted, et cetera, looking at, some like interferon responses or, different pathways, and they call that pathway analysis or so forth. And so that is what we're looking at to get some insight into how the immune cells are metabolically, not metabolically so much, but the proteins that are being expressed give you insights into kind of what their functionality is. And so, and that's what we're doing, RNA sequencing on NK cells isolated from the blood. And so you don't have to, but we generally try to purify or isolate this cell population we're looking at, so it's more of an apples to apples comparison. Because if you obviously just sequence, a pool of cells, you don't know what's sort of driving the differences you're observing, because maybe there's just more NK cells in that patient's blood than others, versus this NK cell is more proliferative or more activated or so forth.
Great, thank you. Well, we're looking forward to, we'll have you on again, hopefully when you have results from the other, it's nice that the study has been a great launching pad for the study to kind of have the IL-15 in between amputation and chemo, and then also in combination with the TIGIT blocker. So really great stuff. Thank you so much for joining us on Osteobites today.
Yeah, thank you. It's been a pleasure.
For osteosarcoma patients, both human and canine, everywhere. More information on this and all Osteobites can be found on YouTube, on our website at mibagents.org, and at your favorite podcast place. And please join us next week on Osteobites on the 8th, September 8th. We're going to be talking with Dr. Nathalie Gaspard. She is a pediatric oncologist at Gustave Roussy Cancer Campus in Villejuif, France. And she's going to be giving an update on a phase 1/2 study of single-agent lenvatinib in children and adolescents with refractory or relapsed solid malignancies and young adults with osteosarcoma. And note, we are at a special time next week because Dr. Gaspard is in France and we didn't want to make her stay up super late. We will be on at 12 p. Eastern instead of our regular 3 p. Eastern. So put that on your calendar, 12 o'clock Eastern next Thursday. And you can find the rest of our lineup for the year on our website. And if you find any ideas for future episodes or topics you'd like to hear about, just drop us a note. Thank you again, Dr. Canter, Dr. Rebhun, and Vicki for spending an hour with us today, and to our sponsor, BTG Specialty Pharmaceuticals. And thank you for joining us today on Osteobites. We hope to see you next week. Thanks so much, everyone.